Hi, I'm David Kerr, Professor of Cancer Medicine at the University of Oxford. I'd like to talk today about a really lovely paper that's just been published in Annals of Oncology by an outstanding French group. As you know, we're very interested always in precision medicine about trying to improve how we match drugs to patients, their tumor genotype, their pharmacogenetics and so on, precision cancer medicine. We've done a really nice piece of work looking at how we can identify patients who are likely to be more responsive to immune checkpoint inhibitors. So it's about 110 patients with metastatic colorectal cancer who had been treated with PD-L1 inhibitors plus or minus a CTLA-4 inhibitor. So a reasonable cohort to study. They correlated looking at DNA and RNA sequencing. They took a discovery, then validation approach across this cohort. What they found was really interesting. So things that we had considered as reasonable markers of response, tumor mutational burden, some other work that had been done, taking a deeper dive into microsatellite insufficiency, looking at infiltrating immune cells, things that seem very plausible in terms of identifying patients who would respond better to immune manipulation, if you like. These didn't figure when they did when they made their deep sequencing effort. What they discovered was that there were some particular differences if you take a harder look at the genes associated with microsatellite instability, and the whole set of RNA sequences, 182, which were around the transforming growth factor beta pathway. We know that TGF-beta is a very important player in terms of controlling the immune microenvironment. It has an anti-immunological effect. So by putting these two new components that they've discovered through the sequencing experiments, they've come up with a rather nice set of biomarkers that do identify patients with a significantly higher chance of responding to treatment. So a lovely piece of science, and a really good approach in terms of using the discovery, then a validation set. Numbers still rather small, one would have to say. So extending the size of their observation, I think, would be important. Testing it prospectively. The question is, if patients did not have this positive selection biomarker, would you not treat them with the immune checkpoint inhibitors? I think the answer probably would still be no. So you could super select patients who are likely to do very well, but I think the work is not compelling enough to see that there's a group of patients who don't have this signature that we would not treat. But it shows how the field is moving in the right direction. It shows how by taking this deep sequencing approach, new biomarkers can be discovered. And clearly this is all to the good. Wouldn't it be wonderful to have a biomarker that was binary, that said these still expensive drugs are effective in this group of patients and completely ineffective in the other group? Having that sort of binary discrimination would be enormously helpful in terms of selecting the right patients at the right time. It would have huge health economic benefits and so on. So a step in the right direction, not quite there yet, but a very commendable piece of work, and what I'd be very interested for you to have a look at and post your own comments. Do you think this is a step in the right direction? And can you imagine in your own clinical practice using these sorts of biomarkers to super select patients that will benefit most? But perhaps above all, in your practical clinical experience, what are we looking for a biomarker that selects patients who will have that increased benefit? How discriminatory need it be between good and bad, yes and no, effective, ineffective? Where do we draw the line? And for that, I think we need to do some perhaps wider work looking at the wider community of oncologists to get feedback from the front line. So to those of us who are interested in biomarkers, what do we need to design in to our biomarker studies to make them sufficiently compelling to be used by the clinical front line? I'd be very interested in your ideas. Thanks for listening, as always. But for the time being, Medscapers, over and out. Thank you.